we know there's lots of ways, lots of materials, lots of types of restorations. This is one approach. This is my favorite approach. This is an FP3. It's called the thimble restoration. So a thimble bar is basically a titanium bar or chrome cobalt or whatever the other materials, but usually titanium, where it's got individual preps. And so every tooth has its own prep. And now you can put a cemented tooth or a bonded tooth onto that thimble, and each tooth is its own entity, basically. So you're creating like basically a one big giant, full mouth rehab, and then you're making individual teeth. So, what are the benefits of this? You're getting the benefits of, you got zirconia teeth. So you're not going to probably break the zirconia teeth any more than they'd break something else. It's like when you restore a full arch with zirconia, usually those crowns, unless they were like under reduced or too thin, they're usually going to hold up pretty well. And then you've got a metal splinted connection, splinting all your implants, which is just a really nice way. Metal to the multi-unit abutment is just ideal long term. And you've got this metal bar underneath the whole thing, the individual zirconia teeth. I mean, they call it the bulletproof restoration because it's just got kind of the best of all aspects of the materials. And if a patient got hit in the front tooth with a bat or whatever and broke it, call your lab, hey, remill me number 8, and they send it over, and you literally just bond it right back on, no harm, no foul. So if you milled an entire zirconia, monolithic zirconia hybrid where the whole thing was one zirconia, and they break number 8, you're screwed. I mean, you got to have an entire thing remade. And so this kind of segments it, breaks it down. Some labs like to do each individual crown. Some labs like to do sextants, like posterior bridge where they're fused, and then anterior and a posterior, kind of up to your lab. Yeah, so if you're going to do these cases, you don't want to deal with fractures. It's like, patients they pay a lot of money. You don't want to deliver stuff that's going to fracture. Acrylic, the traditional metal acrylic hybrid that is so commonly done. You got to have a lot of restorative space. They're prone to fracture. The teeth bust off like a denture. A lot of issues that can happen from that. And then the full monolithic milled zirconia has the issues of having tie bases bonded in, or if they crack it or it breaks, the whole thing is just screwed. So I like this. Does anybody have any experiences with other restorations and materials that they really like for long term, or any other thoughts on this?
These can be co-welded back together. So I'm in the middle of a patient that had one of these existing from the previous dentist. One implant failed at the back. Mm-hmm. Went to go see the oral surgeon. He replaced it. Mm-hmm. And they're coming in, I think, in a couple of weeks to see me for some sort of pickup impression. The lab's going to guide me through, and then they're going to cold weld this. Yep. They're going to cut that, send it back to me in 2 pieces. Yep. I do some sort of pickup in the mouth, and they can cold weld that titanium back together. Yep. And put new crowns on it. So I haven't done it. Have you done it before? It's Ryan that's going to be doing it, but so they can be repaired too if there's a failure. Yeah. So you would basically do some sort of PMR with an impression coping on the new one that's all maybe splinted, or connect them together with composite or something. Just splint them together, and then they'll cold weld it in that position. Yeah.
Now you have the master cast. And they can just cold weld onto that titanium bar, mill out a new tooth. I mean,
the patient's just in their provision.
Okay.
So the implant had failed. Well, I took it out and then sent it to the oral surgeon. He replaced the implant and just put it in the provision.
Nice.
And so we're waiting to fix this, I guess.
And there you go. Hence, you have a master cast. Once you're done with these, you take their temporary, and you keep that temporary on the master cast in your office. Right? These are the forever cases that you keep. So if you're keeping any cases, these are the ones. You just make a section in your office.
That's a struggle. That's Michael Brum's case.
What is?
That right there.
Oh, is this?
Yeah, that's struggle. That's Michael Brum's.
Looks like it.
Oh, yeah. That's Lisi Press. It's
gorgeous. Okay, so let's take a look here. Reasons for thimble pricing. Okay, so the reasons, FP3 usually, so pink gingiva is going to replace the gingival architecture, which is just simpler. You got titanium bars, zirconia teeth, so it's bulletproof. lower restorative space, so kind of in that 12 to 15 world. Repairable, like he was saying, monolithic is brittle, unrepairable. No tie bases, so tie bases can debond from a restoration. So I hear a lot of complaints with full monolithic milled zirconia hybrids, tie bases coming debonded. And then individual crowns, every crown is digitally stored with your lab. All you got to do is email them, hey, number 8 broke, and they could remill you and you could bond it on. And I've done that on one. I went through and had a patient, and I literally just emailed my lab, hey, I need number 5 again. It was there within like the week, and just bonded it on. It was no big deal.
Couldn't you just scan it with an intraoral scanner like a traditional crown too?
Yep. Yeah, you could. Yep, because it's like a prep.
Just a prep.
The metal scan, okay?
Not great.
Powder or something.
Yeah, depending on your scanner. But in this case, they designed the crowns. They milled it. They know what goes on there.
They just had a digital.
They had the file. And it was just a remill. So the patient had to do nothing. So this was a Wyand case actually. So hear that? So that's one of the reasons why I showed this video. Zirconia against zirconia in a fixed world, clack, 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 clack. So that is the downside of double zirconia teeth. So you got to have that discussion beforehand with the patient, and we can deliver you a bulletproof restoration, upper and lower, but be prepared, clack, 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 it's loud. And so you can talk to that patient about it and kind of set expectations, and they may go, I do not want that, Your alternative is you're going to have to do something on the lower, different. You're going to have to do something that's like a resin base, like some of the newer materials. You're going to have to do something that's not zirconia on the lower, and prepare the patient that, hey, it's going to have less strength, but you're not going to have as much of the clacking noise.
I don't know if you do it with Wyand. So they send a little card, and they say that you can get Essex trays. I have one patient particularly that wears through the Essex trays. She wears them all the time, and she's just tearing through them. And she just comes and gets them on.
So she wears them all day?
She does. She's like 84, and her masseters are huge. Like she knows that when she's resting, she's clenching and chewing and grinding around.
Wow.
But there's some other ones that have mentioned the clacking, so they just wear a lower Essex.
I've never heard that complaint, but again, I only have 2 patients from the previous doc that had full arch upper and lower in the IC hybrids. And I hadn't had a clanking complaint.
Good, yeah. And this guy was fine. He hasn't said anything, but.
When would it matter? Is it when they're talking that you'll get actually like a clink, clink, clink when they're talking, or when you're chewing food, it's not going to matter?
Sometimes they'll just do it. Like older patients, they just.
If they're out to dinner with people too, and the teeth are clicking, they'll be embarrassed.
Yeah.
Like that.
Yeah.
That's the potential, yeah.
And sleeping with the significant other.
Sleeping apnea, I can understand.
But they should be in something anyway.
Yep. So just something to consider. Good to be aware of.
Yeah.
All right. So here's our guy that we did the PMR on. So the PMR went off to the lab, then they send it back. Here's the final. This is an IC hybrid. This was from our lab here. This is the IC hybrid on the top, still a temporary. This is a printed temporary on the bottom. Here's kind of what you want to look for. Now look right here. Look how it's a little bit. I don't know if you saw that. It was a little concave on the back. So that wasn't quite ideal. See that? Just a little concave. So just something to be thinking about. You want to make sure keep your lab honest and make sure that they're making those restorations convex under there. That's all. This is a composite. Some labs will use composite, pink composite. Some labs will use acrylic. If you had some pink composite, you could go in. You could maybe add in a little bit here, kind of round it, take a little off the edge. You could reshape it yourself a little bit. You might have to relieve the tissue a little bit, but ways to fix it. So here is that's an upper IC hybrid against that's a lower temporary, printed temporary down there on the bottom.